from the School of Medicine at the Monterey Institute of Technology. Fertility preservation and assisted reproductive technologies in breast cancer patients interrupting adjuvant endocrine therapy to attempt pregnancy. Dr. Azim.
Thank you very much, Dr. Arteaga. Good morning, everyone. So these are my disclosures. So almost 10 years ago, we presented for the first time that pregnancy after hormone receptor positive breast cancer does not increase the risk of recurrence. However, one main question that was raised that obviously these women require treatment with adjuvant therapy, endocrine therapy for 5 years or even more. So the question was whether it would be safe to interrupt endocrine therapy because a lot of these women would not really necessarily be able to wait 5 or even longer duration in order to attempt pregnancy. So this was the reason why we started the POSITIVE study, which was a multi-center international investigator-initiated trial, trying to look into the safety of temporary interrupting endocrine therapy to allow pregnancy, following by resumption of endocrine therapy afterwards. So in this conference last year, and Partridge presented the primary analysis of this study that shown that temporary interruption of endocrine therapy to allow pregnancy does not increase the risk of recurrence at the median follow-up of 41 months. However, given that fertility potential declines by age and that adjuvant systemic treatments often affects ovarian function parameters, including menses, and may compromise chance of future fertility. Furthermore, that ovarian stimulation often required for fertility preservation or assisted reproduction increase hormonal levels, which could be of concern in patients with hormone-sensitive disease. The question remains if it's safe to preserve fertility using ovarian stimulation and or use of assisted reproduction in women with early hormone receptor positive breast cancer. And this was the focus of the results presented in this year's conference. So in the current analysis, we evaluated different parameters. We evaluated menstruation recovery at 6 and 12 months after enrollment in POSITIVE, pregnancy rates at 1 and 2 years, the factors associated with a short time to pregnancy, the association between the use of assisted reproduction and achieving pregnancy, whether the use of assisted reproduction would increase the chance of getting pregnant. And finally, we looked into the association of the use of ovarian stimulation, which is a procedure used either to freeze embryos or oocytes, and this is usually done at diagnosis before initiating chemotherapy or systemic therapy, or the use of assisted reproduction as ovarian stimulation as a mean to assist reproduction after enrollment to the study. So on the right side, this shows the patient flow chart. So a total of 518 patients were enrolled in POSITIVE. 516 were evaluable for the menstruation analysis, and some 497 patients were evaluable for the fertility preservation and assisted reproduction analysis. Overall, in the study, irrespective of the use of assisted reproduction, around 75% of women had at least one pregnancy on study. So if we look first into the menstruation resumption analysis, so out of 516 eligible patients, nearly 2/3 of women were 35 years or older on study. Around half of them reported no menstruation at enrollment, which is quite expected because a lot of these women were treated with GnRH analogs to ovarian function suppression as a part of their adjuvant endocrine therapy. Almost 2/3 received adjuvant chemotherapy, so it's quite expected that we have some 50 to 55% of patients that had no menses at enrollment. What was quite encouraging that almost all women resumed menses on study. And I think this, in a way, is relatively higher than what maybe a lot of physicians would expect. So 85% of, most of them resumed menses during the first 6 months, 85%, and 94% resumed menses by 1 year. Looking into time to pregnancy, we found a clear association between young age at enrollment and shorter time to pregnancy. So the younger the patient, the shorter that, so at 1 year, 64% of women less than the age of 35 at the time of enrollment had at least one pregnancy, compared to 38% in women aged 40 to 42. And at 2 years, 80% of women less than the age of 35 at enrollment had at least one pregnancy, compared to 50% of women aged 40 to 42. So we've done what we call a multivariable model. So we put a lot of factors in the same model to see what are the factors independently associated with a shorter time to pregnancy. And the only factor that mattered was age. So, meaning that if you use chemotherapy or not, if you give GnRH analogs with chemotherapy, the type of endocrine therapy, even if the patient had menses at enrollment or not, this did not really matter to have a shorter time to pregnancy. What mattered the most, young age. So this slide summarizes data on fertility preservation and assisted reproduction in the positive trial. So the first part, for fertility preservation, around half of the women underwent some form of fertility preservation. And this happened at breast cancer diagnosis, meaning before being enrolled to positive. So the most common used modality is ovarian stimulation for embryo or oocyte cryopreservation. This was performed in nearly 1/3 of the enrolled patients. The second half of the slide resumes the assisted reproductive techniques that were used on the study. 43% underwent some form of assisted reproduction, and this happened obviously after being enrolled to positive. The most common was either ovarian stimulation for IVF, in vitro fertilization, or the use of the cryopreserved embryos that were performed before, that transfer them back into the body. So we did, again, a multivariable model to see what are the assisted reproductive technologies that increase the chances of getting pregnant, and adjusting this model to age and the use of chemotherapy. And we found that the cryopreserved embryo transfer was the modality that was the only modality significantly associated with increasing the odds of becoming pregnant, with an odds ratio of 2.4. Again, we found that age mattered a lot. In other words, women less than the age of 35 had a 50% higher chance of having a pregnancy compared to women aged from 35 to 39, and even an 84% higher chance of having a pregnancy compared to women aged 40 to 42, and this is independent of the use of assisted reproduction. Finally, we looked into breast cancer outcomes, and on the left part of the panel, we looked into the use of ovarian stimulation to freeze embryos or oocyte at breast cancer diagnosis for fertility preservation. And we found that at 3 years, breast cancer-free interval was almost identical between both groups, those who underwent ovarian stimulation and those who did not, 9.7% compared to 8.7%. On the right part of the slide, whether the use of ovarian stimulation after positive, in order to do an IVF, in vitro fertilization. And obviously we had very low number of events here. This was a landmark analysis at 2 years. We had very low number of events, so we cannot really draw very solid conclusions there, but overall the event rate was very low. So these are the main take-home messages. Obviously this is the largest prospective study to investigate fertility preservation and assisted reproduction in patients with early hormone receptor positive breast cancer desiring future pregnancy. We found that embryo or oocyte cryopreservation at diagnosis, followed by embryo transfer, had higher pregnancy rate and was not associated with worse prognosis, underscoring the importance of early fertility counseling for young breast cancer patients willing to preserve their fertility later on. There was no increase in breast cancer events in patients undergoing IVF, albeit with very few events. A word of caution, we know quite well, and I think this was discussed earlier today, ER-positive breast cancer is a disease with tendency of long-term recurrences. So in this study, we have a follow-up of 41 months, so around 3.5 years. So obviously, we need to follow up these patients to understand the implications on the long-term outcome. This is obviously applicable for the approach of temporary interrupting endocrine therapy, but obviously as well these results. But in a way, this is rather reassuring, at least on the short term, that it does not appear that we are harming patients on the short term with these interventions. By that, I'm happy to take any questions. Thank you very much.